So I'm a physician just by training. I'm board certified in the subspecialty of molecular genetic pathology, and I oversee the molecular pathology laboratory at the University of Iowa Hospitals and Clinics. The 2 points that I want to emphasize today concern patient safety and patient access, because patient safety is one of the concerns that FDA promulgates as a reason for the draft guidance. So laboratories like the one that I direct at the University of Iowa work within a multi-pronged and stringent regulatory environment consisting of federal regulation under the Clinical Laboratory Improvement Amendment, or CLIA, as has already been mentioned, state regulations, biennial and annual inspections, regular assessment of test quality through proficiency testing programs, which I'll discuss in just a little bit, and the application of clinical practice guidelines by our professional colleagues. So under the current CLIA process, all laboratories providing clinical testing must be inspected every other year by certified inspectors and perform internal inspections on the opposite years. We have to document all of our findings and correct any of the problems that are identified. Inspectors review all aspects of clinical testing, from the test reagents and instruments that we use, all the way to the professional training of the staff that perform the testing in our laboratories. And this is to ensure that we are performing testing accurately and not reporting results incorrectly. Furthermore, every procedure in every clinical laboratory, whether we're calling about laboratory developed tests or any other laboratory testing, must be tested through proficiency testing every 6 months. And this is the process where we evaluate the performance of the tests that we use in clinical laboratory medicine. We use specimens that are blinded. These are usually provided by an outside organization like the College of American Pathologists for a lot of the things that we do testing. We provide the results back to them. They grade them. It's a pass or a fail. If we fail, then we have to stop testing and figure out what was wrong with our tests. Like I said, this has to be done with every laboratory test every 6 months in any clinical laboratory providing patient testing. Whenever we make changes to the assay, we get a new lot of reagents, we perform maintenance to the instruments, or even the software upgrades that we have to perform. We have to repeat testing to verify that the instrument and the assay are still performing the way we expect them to. So no clinical laboratory testing can be performed in the U.S. without having a CLIA license and accreditation through the inspection process. And so we would argue that, in fact, the testing that we're performing is safe under the CLIA process, and that our utmost is to provide the best patient care and safe patient care that we can. The second point that I want to emphasize is that we're concerned that the FDA draft guidance would force us to ignore current medical knowledge. We are healthcare providers. We're required to meet certain requirements of our professional and state licensing boards, and we see firsthand the impact of using molecular procedures in the context of caring for our patients. We see when new tests need to be developed or existing tests need to be changed to apply emerging medical knowledge. So I want to highlight one example with testing for a gene called BRAF, where we've seen a really significant evolution in our understanding of its role in cancer, and we now have chemotherapeutic drugs to target it. Many cases of melanoma skin cancer, very common type of cancer, carry mutations in the BRAF gene. And these mutations change the protein so that it causes it to be constantly active in the tumor cells. It's a growth promoter in the tumor cells. Targeted drug therapy was developed to block this activity in this mutated BRAF protein. And patients who have the BRAF mutations are candidates for this therapy. It's been a revolution in treating melanoma patients. So there is a companion diagnostic that is approved for testing patients with metastatic melanoma, and it's a very sensitive assay. but it's limited to detection of the common mutation in the BRAF gene. And we now know that there are many other mutations in the BRAF gene that can cause it to be activated and would be a target for this chemotherapeutic intervention. So my lab, other labs around the country have recognized that there's this diversity in mutations in the BRAF gene, and that we needed to be able to provide accurate testing to identify those changes, to accurately identify patients who would potentially be responsive to this drug. So in our lab, we continue to use our laboratory-developed procedure because we were able to detect these additional mutations and able to provide more accurate information to the clinician so that they could provide better care to patients with BRAF mutations, with melanoma. Patients and their families are demanding that their care be based on current medical knowledge. I ask you, wouldn't you want this for yourself or a family member? So in summary, let me emphasize that laboratory-developed procedures are safe, and that this draft guidance has the potential to freeze tests in time and not be able to adapt to the growth in medical knowledge